Talley and O'Connor. It doesn't have to be a full Talley and O'Connor review, but I would suggest being aware of things that you might be expecting, you know, testing for clonus, testing for tone and rigidity, thinking, okay, why am I testing for this? Are you looking for a serotonin syndrome and neuromalignant syndrome?
In terms of neurological assessment, I mean, again, it's quite a broad topic, so you'd have to think about just what are you looking for? What are you concerned about?
I would get pretty comfortable with it. Looking at gait, you know, is very important. So I guess having a rationale and then an approach for your neurological exam. If you're trying to exclude a neurological event or something like that you're thinking, okay, there's something else going on here, then I would probably go a little bit deeper into the detail.
Most common neurological exam that I would use would be the AIMS exam. So the AIMS exam is looking for abnormal involuntary movements, particularly dystonias, pseudo-Parkinsonism, akathisia, tardive dyskinesia. So it would be looking at the mouth, getting them to open the mouth with the tongue at rest, and then poking the tongue out, testing for tone, looking for tremor, looking for bradykinesia by getting them to tap their fingers on their thumb. Also looking for a shuffling gait, stooped posture, other signs of Parkinsonism.
Cognitive testing you can do with a MOCA or an MMSE for the A1 purpose. Most people will check if the patient's oriented and say grossly intact, and that's usually quite sufficient. If you're admitting someone or you have a specific thing you're looking for, it's just a neuro exam as normal, but just make sure you're having a look for involuntary movements, so signs of Parkinsonism, tardive dyskinesia, or your EPSEs basically. But cognitive testing, you can do an Addenbrooke's if you want to get real detailed, or a MOCA, but generally an MMSE will suffice unless it's a pretty significant problem.
I mean, anyone can ask the registrar as how to do an AIMS exam. And I think we probably don't do it as often as we should. We should probably do it more often.
I think it's always good to do a little bit of a test of cognition. You can often pick up things like attention and concentration just in an interaction with a patient. I think using your MMSEs and your ACEs are really useful.
In terms of cognition, my favourite screen would be the MOCA, because it incorporates more aspects of executive functioning and more tests that are relevant to the frontal lobes and subcortical systems. So it'll test verbal fluency. There's a trails test in there. So they're the things that are more helpful in helping us to determine whether there's cognitive impairment in our clinical population. And it's quick. It's much quicker than an Addenbrooke's.
Mini mentals are a really good test to use because it's really quick, easy to do. You can do them serially, and there's very little inter-person bias of whoever's sort of running the test. And the ACER has some really good sort of evidence behind it in terms of how accurate it is.
And taking a step back from the neuro exam, I mean, I'd rather not have to be testing someone for a hemiparesis. And what I mean by that is we should probably be doing more physical exam targeted at the metabolic side effects of antipsychotics, so waist circumference, BMI, because they are going to be risk factors for stroke and heart disease. So that's something that we certainly don't do enough, that we should do more of. And probably during ward rounds, talk about more and monitor in a more systematic fashion.
Like the mental state examination, these exams are not so useful just when you do them cross-sectionally. And it's important when you are doing them that you're doing them on a patient that's appropriate for the test to be done in. What I mean by that, if someone's recently had a systemic illness, they're recently in crisis, they're recently gone through something traumatic, could affect the accuracy of the result you receive, because their level of concentration and attention during the examination can be compromised. So it's important to wait till they're at a baseline or settled in terms of their sort of behaviour and presentation on the ward before going charging ahead with cognitive testing. That would be the only useful piece of advice I'd have on that.
Remembering that when someone is delirious, that means that their attention and concentration is poor. Okay, and so, but if you're testing kind of long-term cognition and whether someone is developing an impairment, using something like an ACE and comparing it using serial ACEs through time, which, you know, is nice when you've got the time to do that and can, you know, compare scores, but it is very useful. And also keeping in mind that when people are suffering from an acute mental illness, there will be deficits in cognition, and if you're wanting to test their level of global impairment, to test it once they've been treated for their mental illness and are in remission.
I mean, other areas of the physical exam that I think can be helpful are dentition, skin, particularly looking for abscesses at injection sites, things like that you can tailor to the patient, but ultimately just being mindful of their physical health.
No different from what you've probably and hopefully learnt in med school. There's nothing extra fancy that we do. It's the same cognitive test that we use. It's the same exam that we use. The only thing is you might come across a lot more Parkinsonism and a lot more movement disorders because of the side effects of the medications. Nothing else, basically. It's the same.